We're now going to start the reproductive physiology section, which may seem complicated at first, but which actually makes a lot of logical sense when you really get down to it and have a solid grasp of what all of the different hormones actually do. Anyway, let's get started. We're going to pick up right from the previous section with spermatogenesis. Spermatogenesis begins at puberty and takes about 2 months from start to finish. As mentioned earlier, the spermatogonia mature into spermatids, which lose their cytoplasmic contents and gain an acrosomal cap to form mature spermatozoa. As a quick review, spermatogonia are basically the stem cells of spermatogenesis. They divide to form primary spermatocytes and also to replenish the pool of spermatogonia. Primary spermatocytes are the first cell type committed to differentiate into mature sperm. They begin as diploid cells with each chromosome consisting of 2 chromatids and undergo meiosis I to become haploid secondary spermatocytes. They still have 2 chromatids for each chromosome until they undergo meiosis II, resulting in spermatids that remain haploid but now only have 1 chromatid for each chromosome, meaning they only have 1 copy or half the normal amount of genetic material in somatic cells. These spermatids will go on to form mature spermatozoa through the process of spermiogenesis, during which they lose almost all of their cytoplasm and gain an acrosomal cap. For regulation of spermatogenesis, it's important to note for the boards that there are 3 main levels of regulation: the hypothalamus, the anterior pituitary, and the gonads. Starting at the top, the hypothalamus releases gonadotropin-releasing hormone, which stimulates the anterior pituitary. The anterior pituitary releases FSH and LH. Follicle-stimulating hormone stimulates the production of androgen-binding proteins by the Sertoli cells, which supports spermatogenesis. Sertoli cells respond by secreting inhibin, which provides negative feedback. Luteinizing hormone stimulates the Leydig cells to release testosterone, which in turn stimulates sperm production. So let's talk a little bit more about androgens. In addition to testosterone, there are 2 others you need to know about: dihydrotestosterone, or DHT, and androstenedione. They have different potencies for the androgen receptor. DHT is the strongest, followed by testosterone, followed by androstenedione. Testosterone stimulates differentiation of the epididymis, vas deferens, and the seminal vesicles, but not the prostate, which is stimulated by DHT. Testosterone is also important in puberty, where you see a growth spurt, deepening of the voice, and eventual closing of the epiphyseal plates through aromatization of testosterone to estrogen. This ends linear growth. Testosterone is also very important in driving libido. Testosterone is converted to its more active form, DHT, by the enzyme 5-alpha reductase. DHT acts early in development to differentiate the penis, the scrotum, and the prostate. Later in life, it primarily acts as a prostate growth factor and also causes balding and sebaceous gland activity. So here's a question for you. If too much DHT is responsible for prostate growth, what would be a good treatment for benign prostatic hyperplasia? The answer is finasteride, which is a 5-alpha reductase inhibitor that stops the conversion of testosterone to DHT. As you may know, finasteride is also used to treat male pattern baldness. This explains why one of the major side effects of finasteride is gynecomastia. There are 3 major sources of estrogens that each produce a different type of estrogen. The ovaries produce estradiol, the placenta produces estriol, and adipose tissue produces estrone. Estradiol is more potent than estrone, which is more potent than estriol. As seen in the image, as in the male, there are 3 levels of regulation for estrogen production. First, the hypothalamus releases pulsatile GnRH, which stimulates the pituitary to release FSH and LH. Constant GnRH release actually inhibits release of FSH and LH, but more on that later. LH functions on the theca cells, stimulating the conversion of cholesterol to androstenedione via desmolase. FSH stimulates the granulosa cells to convert androstenedione to estrogen via aromatase. Estrogens serve many functions. Estrogen stimulates the development of female genitalia, breasts, and is responsible for female fat distribution. It is also responsible for the growth of the follicles, endometrial proliferation, and increased myometrial excitability. Estrogen is involved in regulating secretion of hormones like LH and progesterone, and prolactin, as well as production of sex hormone binding globulin. SHBG has a higher affinity for DHT than for testosterone or estrogen, so when levels are high, circulating levels of active DHT are lower. Naturally, when estrogen and SHBG levels are high during pregnancy, free serum DHT concentration is low, whereas after menopause, estrogen and SHBG levels are lower, resulting in higher circulating levels of active DHT. As a couple final thoughts before we leave the estrogen first aid fact, as I mentioned earlier, the placenta is the primary source for estriol, so it's no surprise that during pregnancy you get a much bigger increase in estriol compared with estradiol and estrone. Finally, let's talk about scenarios involving a breakdown in estrogen regulation. So what happens when a female has no aromatase? These patients, because they have low estrogen levels, can present with primary amenorrhea, ambiguous genitalia, and virilization. Men have a different phenotype in which they grow tall and show early signs of osteoporosis. Aromatase deficiency is actually an autosomal recessive condition, and a pretty rare one at that, but it definitely has the potential to show up on boards questions. As we will discuss later, a similar condition can be induced pharmacologically via aromatase inhibitors like anastrozole and exemestane. We often induce estrogen deficiency in breast cancer patients with tumor cells that are positive for the estrogen receptor. Like estrogens, progesterone is a steroid hormone. It can be found in the corpus luteum, placenta, adrenal cortex, and the testes. The key things to know for the boards are its functions, including increasing endometrial gland secretions and stimulating spiral artery development, decreasing myometrial excitability, increasing body temperature, negative feedback on FSH and LH secretion, and, of course, maintenance of pregnancy, along with uterine smooth muscle relaxation and decreased estrogen receptor expressivity. Like many female sex hormones, progesterone concentration waxes and wanes in cycles related to ovulation and menstruation. Specifically, progesterone peaks in the middle of the secretory luteal phase, approximately 7 days after ovulation, due to secretion by the corpus luteum in order to maintain the endometrial lining in preparation for implantation. Just remember that progesterone is pro-gestation, because it helps maintain the pregnancy. There are 5 stages of sexual development according to Tanner. Stage 1 is childhood. Stage 2 begins when pubic hair appears, called agenarche, and the breasts enlarge in girls, called thelarche. Stage 3 occurs when the pubic hair darkens and becomes curly and the penis size and length increases in boys. Stage 4 occurs when the penis width increases, darker scrotal skin appears and there is development of the glands of the penis, and raised areolae occur in girls. Finally, Stage 5 is adulthood, and when the areolae are no longer raised in women. The menstrual cycle is a very important process to know for the boards, and it can be divided into 2 stages, a proliferative or follicular phase and a secretory or luteal phase. These 2 stages are divided by ovulation. During the follicular phase, estrogen stimulates endometrial proliferation. This phase can have a variable length, whereas the luteal phase is always approximately 14 days. Toward the end of the follicular phase, estrogen levels begin to rise 2 to 3 days before the LH surge and then drop. The LH surge then begins, triggering ovulation. During ovulation, LH and FSH are high, whereas estrogen and progesterone are low. During the luteal phase, the corpus luteum develops from the ruptured follicle and begins secreting large amounts of progesterone, which maintains the endometrium and increases the basal temperature. In fact, an increase in basal body temperature is one of the methods utilized to determine if ovulation has occurred. If fertilization does not occur, however, progesterone levels return to normal, and the corpus luteum regresses, leading to menstruation. A normal cycle length is between 21 and 35 days. As you can see here, the luteal phase tends to be a constant 14 days, so most of the cycle variation occurs in the proliferative or follicular phase. This variation can be due to a number of factors, including stress, infection, and diet. So what if the cycle is longer than 35 days? Well, that's called oligomenorrhea. If the cycle is less than 21 days, then it's referred to as polymenorrhea. To finish up, we have just a little bit of additional menstrual terminology you should know. The term metorrhagia refers to frequent but irregular menstruation. Menorrhagia, on the other hand, refers to abnormally heavy menstruation. So what do you think menometorrhagia is? Yep, it's heavy and irregular menstruation. So let's talk a little bit about ovulation now. During menstruation, we can observe estrogen levels begin to rise as simultaneously the number of GnRH receptors on the anterior pituitary begin to increase. As just discussed in the previous first aid fact, the rise in estrogen stimulates a spike in LH levels, which triggers rupture of the dominant or pre-ovulatory follicle. One benign condition that can occur at this juncture is referred to as Mittelschmerz, which is German for middle pain. Mittelschmerz can occur when the blood released from the ruptured follicle irritates the peritoneum and causes pain resembling appendicitis. The discomfort can also cause follicular swelling, ovarian wall rupture, and fallopian tube contraction. So now that we've gone through a little bit about how ovulation should work, here's a quick question for you. What are some causes of anovulation? If you want the answer, you can peek ahead in the chapter. When we get there later on, we'll talk about causes such as polycystic ovarian syndrome, thyroid irregularities, and hyperprolactinemia.